But all you need is a little
push. Okay. Hi everybody, Ziv Simon here. I'm the creative surgical master. I'm here in my office in Beverly Hills. It's 7:30 in the morning. We've been here since 6:30 recording videos. I'm joined by Dr. Alexander Waldman, my good friend, really the best orthodontist that I know, one of the best in town. He's so good that I referred my daughter to him. You're going to see my daughter Emma. Oh, you saw her already.
Yes.
We started. And we wanted to spend a few minutes talking about the perio-ortho relationship, not in a big sense of a lecture, but more practically, what type of soft tissue problems affect orthodontic treatment, and maybe vice versa, because we've been working together now for how long?
12 years.
12 years, 13, since 2003, and we co-treated so many patients, and we have a very good working relationship. You're very good about identifying soft tissue problems. So from your own perspective, what is the concern when you're seeing an ortho patient and something is going on from a soft tissue point of view?
I think there are a few concerns. The largest concern is that when we are moving teeth, we're changing the dynamic and the mechanical relationships between these tissues, between the teeth, the bone, and the gingival tissues. And it obviously opens up sometimes a can of worms. Most importantly, we want to make sure that...
What does that mean? What does it mean, can of worms?
Well, certainly, we see patients every day in our practice where teeth are moved, particularly adult patients. Kids are a different story. They are affected by orthodontic treatment in terms of their mucogingival health, but adult patients seem to suffer more from this. And it could be for many reasons. They may have very thin gingival tissues. As we move the teeth, we may move the teeth right through the bone and the gum tissue, exposing either new areas of recession or sometimes exposing old areas of injury from periodontal disease in the past or previous orthodontic treatment. One of the common things that I see in my practice are adults who had orthodontic treatment as kids. The teeth have been expanded and there's very thin tissue, very thin bone covering the buccal or labial surfaces of the teeth. You don't really know what's going on underneath the surface. As you move the teeth, you may be moving the tooth into an incredibly fragile environment, and there may have been a homeostasis for many years where the patient just kind of holds it together and doesn't have recession. But all you need is a little push,
Okay.
And you may see some recession, and that's always on my mind as I plan a case.
Okay, no, that's good, and really and that's great, because if you don't, we see certain problems happening after ortho, and really leads to another really important question that a lot of dentists are asking me. Should grafting be done before ortho or after ortho? I'm not sure there's an answer for that, and every case is different, but when you and I are treatment planning cases, and we've done it both ways, what are some of the considerations that we are looking into when we are deciding on the timing of grafting, if grafting is indicated?
Yeah, it's an excellent question. It's obviously something that we struggle with on a daily basis. Sometimes it's obvious it needs to be done, and as you said, the question is just when. I think that when you have a patient where there's going to be significant treatment done, and there's going to be an obvious reorganization of the alignment of the teeth, and perhaps that has implications for the architecture of the bone and the gingival tissues. Sometimes it just simply doesn't make sense to do grafting before treatment
because
suffer the changes that may occur, as we discussed before, from orthodontic treatment, and then maybe have to redo it.
Oh, I see.
So the logic is rather, if we suspect we may get some recession, perhaps treat the patient orthodontically in a responsible manner, that is to say, not to overexpand them, to control the amount of labial or buccal movement of the teeth that may lead to recession. But at the end of the day, if a recession has occurred than to do all of the grafting at one shot. That is one approach that I think is very common amongst my colleagues and friends and how they think about things. On the other hand, if we have a defect which we see would become severe through orthodontic treatment because perhaps the tissue is so thin that any movement of this tooth whatsoever would lead to a significant problem that may be difficult to recover from later, it may be best to get ahead of the problem and to graft it now so that this becomes a reasonable treatment for the patient.
Okay, so basically every case is totally different, and if there is a defect that by applying orthodontic forces will basically push it over the edge and now create a very severe problem that maybe is not even manageable or requires a lot more treatment, it's better to treat ahead of time. But if the recession or the mucogingival problems are, you feel comfortable applying orthodontic forces on, then we probably would delay it. Is that a good summary?
I think it's a good summary.
Okay.
Of course, it's a case-by-case basis.
Okay, good. Case by case. It's always a good answer. Now, a lot of our cases that you and I have been treating over the years involve adult patients, and that's really I see you. I mean, you're a great kids orthodontist, but really, I see this as your specialty. Your work with Invisalign involving orthodontic surgery. But what I wanted to talk about for a minute or two is our implant patients. Creating the ideal, not just implant space, which is the obvious, aligning roots, creating surgical space and restorative space, but how do you see your involvement as an orthodontist in preparation of an implant site?
Well, I think that there's been a tremendous amount of work done in this area, and we stand on the shoulders of giants. Vince Kokic,
Sure.
Bjorn Zackerson.
Bless his soul.
Bless his memory. Some of the real leaders have done work in this area. There's not a lot of new work in this area, but I think that we have enough understanding now to know that the implant space, whether it's a restorative or a surgical space, can be modified in 3 dimensions. Vertically, whether it's through extrusion of teeth that may be sacrificed or not, but creating bone and tissue vertically within the alveolus through essentially a very slow distraction process, essentially.
Destruction of a full segment
of a tooth,
or the actual tooth itself?
Of a tooth. Normally one single tooth. If, for instance, we have a tooth that's going to fail, it's going to be replaced with an implant. But there's no infection, and the tooth is vital, or actually even if it's not vital, and it can be moved as well, to use that tooth to generate bone in a way that surgery would be very difficult to do, because we know vertically augmenting bone is the least predictable. And then, of course, also mesial distally, we can actually take an area that was very thin, move a tooth into that area, and maybe open up an implant space somewhere else where we have better bone. So those are examples of things we can do, and I think that the partnership between periodontics and orthodontics is one of the most vital and interesting in all of the interdisciplinary specialties, because both are, I think, the least mechanical specialties and the most biologic.
I thought ortho is very mechanical.
It is mechanical with the movement,
mechanical.
But if you think about what we're doing, we're moving teeth through tissues, through bone, and we require a cellular response in the same way that we do it in periodontics. Unlike, let's say, well, I guess every area of specialty in dentistry has that, but it's a little bit different.
It's very intimately related, and really always congratulate you for being so sensitive about soft tissues, because quite often, at least in my practice, we see the ramifications of orthodontic treatment when the soft tissues have not been taken into account, like teeth that have periodontal disease, and orthodontic treatment is initiated, leading to, number one, no results, worsening of the ortho treatment, and of course the mucogingival problem. I showed you the case from last week's video where an untreated mucogingival defect can turn into an abscess.
Absolutely.
So
Ziva, I'd actually like to speak about one more area. We've spoken about implants.
Okay.
We've spoken about recession, let's say a need for grafting. There's a third area.
Which one?
Which is periodontal aesthetics.
Okay.
And as we know, many patients have a diagnosis of altered passive eruption.
That's
this is something you've published on, I believe.
Sure.
Certainly has been an interest of mine for a very long time. And, sometimes we simply can't get as beautiful of an orthodontic result because of a gingival smile with the gums sitting too low on the teeth. And of course, there's a huge spectrum of different diagnoses that can cause this problem. However, there's no question that if we have a true altered passive eruption problem, and it's not, let's say, a gingival smile because we have vertical maxillary excess or some other issue like that, there is a tremendous connection and kind of symbiotic relationship between the periodontist and the orthodontist to allow the patient to achieve the goal of why they started orthodontics, to improve their smile. And I think that the work you've done in this has been excellent, and I want to commend you for that.
Thank you so much.
And just to bring it to the attention of the community, because like I said, patients are often not achieving the results even after beautiful orthodontic alignment without addressing the picture frame.
Sure, and restorative treatment.
Absolutely.
At the same time. So that's what I found actually many years back, that the orthodontics can be done beautifully, with beautiful, creating a great bite and beautiful alignment, but the braces come off and the teeth are short, and that leads to disappointment. Now see the periodontist. Now, many times I've seen you do some minor gingivectomies during orthodontic treatment to kind of build up the case slowly and see where the soft tissue is going to end up, and then of course we do the final touches.
That's particularly important in cases with tooth size discrepancies. Now, I'm not a periodontal surgeon, but I did learn.
You did a pretty good gingivectomy.
Thank you. But I did learn from a colleague of mine, Dr. Ken Greenstaff, who's a pediatric dentist, how to use an electrosurge machine back in the day.
Oh, that's a bad word.
Yeah. Oh, it's a bad word. Okay.
No, that's okay.
It's a laser.
No,
it's an old-fashioned laser. It's an old-fashioned laser, and I use it very, very sparingly. But and obviously we can't use it for osseous issues, and that's often involved in these significant gingival smiles. However, one of the interesting areas of interdisciplinary care are tooth size discrepancies. And when we're treating an orthodontic case and we have a tooth that's small, it's very often small not only mesial-distally, but incisogingivally. The tooth is it's a smaller tooth. Let's say number 7, anatomically smaller, and the position of that tooth and placing it properly so that the gingival margin is correct for the aesthetic dentist who's going to complete the veneer or perhaps the bonding on that case is very, very important. Now, the problem is that sometimes during orthodontics we have inflammation, and it's very hard to know where that margin is. If we leave the tooth very short, the dentist perhaps may not be able to bond that tooth, and we get a very unaesthetic square tooth. So little things like that are actually things that can be done in an interdisciplinary fashion to enhance restorative dentistry as well. And I find that the restorative dentist, when you really pay attention to those microaesthetic issues, really appreciate it, because the patient will have a much nicer result, and it will allow them to achieve a much nicer restorative result. So that's an area we can work together actually to help the restorative dentist do a beautiful case.
Absolutely. That's, and the little details are very important and make a big difference. So thank you for spending the time with me and talking about some interesting things. And I'll see you in the next video. This is Dr. Ziv Simon from Surgical Master.